Have you ever stopped to think about your shoulder? I mean, really think about it? It can do so much, but it's also ridiculously easy to injure. It's one of the most common dislocations we see, and the reason why is this incredible story about a trade-off our body has to make. So, let's get right into it.
Okay, let's start with a big number right out of the gate, 95%. When a shoulder pops out of place, 95% of the time it pops out toward the front. We call that an anterior dislocation. Only a tiny fraction go backward. Now that's not just random chance, it's a huge clue that points to a very specific weak spot in the shoulder's design.
So why is the shoulder so prone to this in the first place? Well, it all comes down to its amazing, and I mean amazing design. It's truly a joint of extremes. It's built for a massive range of motion, way more than any other joint in your body.
And here's the catch. All of that incredible freedom, the ability to throw a fastball, to reach up to the highest shelf, it comes at a price. And that price is stability. It's a classic trade-off, really. Like an amazing sports car with tires that are just a little too thin.
This brings us to that design flaw I mentioned. If you picture the joint being held together by a sort of bag of ligaments, well, that bag has a weak spot on its underside. Think of it as the shoulder's own Achilles point. And yeah, you guessed it, this is the escape hatch for the arm bone in almost all of those anterior dislocations. So, when that ball-shaped top of your arm bone, the humerus, pops out the front, it doesn't just go wherever. Most of the time, it lands in a very specific place. It's called a subcoracoid dislocation, which just means the bone ends up sitting right underneath this little hook-like part of your shoulder blade.
Okay, so we get it. The shoulder is vulnerable. We know where it's weak, but what actually causes it to happen? What kind of force does it take to pop that bone right out of the socket? Let's take a look.
So it usually happens one of two ways. The most common one, by a long shot, is an indirect force. You know that classic movie scene where someone falls backward and throws their arm out to catch themselves? That's the perfect setup. Or think about a quarterback winding up for a long pass. That combination of the arm being out, rotated back, and extended, it creates the perfect leverage to just pry the joint apart. Much less often, a direct hit from behind can literally just knock the bone out of place.
So what does this actually look and feel like? For the person going through it, and for the doctor trying to diagnose it, the signs are, well, they're pretty hard to miss.
First, there's just this incredible, intense pain, and you basically can't move your arm at all. You'll see the person holding their arm just a little bit away from their body, almost protecting it. But the real giveaway, the classic visual sign, is that the shoulder loses its normal round shape. That nice curve is just gone. It looks flat, almost squared off, because the top of the arm bone isn't where it's supposed to be.
And get this, there's a really simple physical test for it called the Dugas test. If your shoulder is dislocated, it is physically impossible for you to touch your opposite shoulder while also bringing your elbow down to your chest. The bone is literally in the way.
Now, this isn't just a bone problem. As that bone gets forced out, it can stretch or even damage the nerves that run nearby. The nerve that gets hit most often is the axillary nerve, and when that happens, it can cause a very specific patch of numbness on the outside of the upper arm, right around where a military uniform's regimental badge would sit.
All right, the diagnosis is clear. The shoulder is definitely out of the socket. Now comes the most important part of this whole story, getting it back in. The process we call reduction. And I have to be really clear here, this is a medical emergency. You do not want to try and fix this yourself. It needs to be done and done soon, but it has to be done gently to avoid making things worse. That's why it's often done under anesthesia, to help relax all those muscles that are spasming around the joint. Now, the most common way to do this is a sequence of moves called Kocher's maneuver, and there's a fantastic little acronym to remember the steps. TEAM. It starts with T for traction, a gentle pull on the arm. Then E for external rotation, slowly rolling the arm outward. Then A for adduction, bringing the arm across the chest. And finally M for medial rotation, turning the arm inward. When you do it right, these steps gently guide that bone right back home.
Now, Kocher's is the most popular, but it's not the only trick in the book. There's the Stimson method, where the patient lies face down and lets gravity and a little bit of weight do the work. And then there's the really old school one, the Hippocrates maneuver, which uses a foot in the armpit for leverage while pulling on the arm. A bit more direct for sure.
So, the shoulder's back in. You hear that satisfying clunk, and the relief from the pain is almost instant. But the journey is not over. Not by a long shot. Now we get to the final and maybe most important stage, the path to recovery. 3 weeks.
Once that shoulder's back in place, it needs to be immobilized in a sling for about 3 weeks. And this part is absolutely crucial. Remember that ligament bag we talked about? It's all stretched out and damaged. It needs this uninterrupted time to heal, to shrink back and get tight again. If you rush this part, you're just setting yourself up for another dislocation down the road.